Hello, everyone. Perfect. Okay. Hello, everyone, and welcome to this Wednesday Q&A. I hope your studies are going well. So for this Q&A, it is very casual. I'll just be online answering people's questions as they pop up. I do have a couple of I do have a couple of items I want to just chat beforehand. Just some general items for doing well on the exam. Oh, I'll get someone to. Okay. I'll get you guys to mute your phone if you can. I'm just getting some feedback from some people. I'll mute these people. And so you can't see it, but I actually have to admit people in, and I'm also watching the chat as well. So there'll be times where I'll be kind of doing some other stuff. But yeah, so first couple tips first is that uh, what's most important on the exam is just to keep calm. If you ever feel that you're starting to read the question too fast or you're getting anxious, just take 7 deep breaths, just like you, because, oops, I can mute people. Just take 7 deep breaths, just like because seven is the target for your A1C. So just slow down and take 7 deep breaths to keep calm. The other tip is that, as I discussed in the Start Here page, there's going to be a whole bunch of pilot questions on the exam. And those pilot questions, even if you get them right, they aren't worth any marks. So it's important that if you get stuck or something like that on a question, don't spend too much time on it. Time is your most important resource. And so if you do get stuck on a question, don't spend too much time on it. Just mark it to check later and continue on. Lastly, there's pros and cons to writing the exam at home. Since it is at home, try to just make it as comfortable as possible. If you find like lavender is calming, have like a lavender infuser. If you are a spiritual person, you can have a figurine of a god or whatever you believe in to calm yourself down. You could just have a picture of your family to make you nice and relaxed. You can try to make the environment as comfortable as possible. Let me see here. Okay. And yeah, so those are my general tips. There's no agenda for this. Oops, oh, there's always people waiting. Just 1 second. I have to admit all these people. Okay. So there isn't an agenda to this presentation. Whoever has a question that they want to ask first, please go ahead, and we'll just kind of slowly work through questions together. Yeah, you can either unmute yourself or type in the chat. And this is a very casual session. You can come and go as you please. But yeah, feel free to ask your questions. Okay, here we go. Um, just to confirm the macronutrients for protein. No, so on the macronutrients, for the macronutrients, there's actually one for the general population and one for people with diabetes. So do you know which page number, Anna, that you're referring to? Okay, it should be, let me see here. Protein. It should be the same as before. This chapter hasn't been updated. So whatever it was before should be the same as now. There's a certain percent macronutrient. There's a certain percentage that it should be on. Here it is. 15 to 20%. Is that what you were looking for? Okay. I hope that answers your question, Anna. So Kajal asks, any advice on what we should focus on, particular for the pregnancy population? The chapter was huge, and so not sure if there are things more likely to show up than others. So yeah, unfortunately, the pregnancy chapter is huge. Part of the problem is that it's difficult to do research on pregnant people, and so that's why there's like multiple methods and things like that. I do. I did hear that they plan to update that chapter soon. So hopefully they can make it more streamlined and so that they don't have, uh, these multiple ways of doing things and things like that. Um, in for anything to focus on, just the stuff that I highlighted on the study guide would be my suggestion. Um, yeah, that unfortunately, Kajal, that is a big chapter, and yes, there's lots to memorize from it, unfortunately. Oops, Jesus, so many people in to admit. 1 second. Okay, there we go. Perfect. Okay. Next question. Hi, I was wondering about guidance re missed doses of basal insulin realized later in the day for type 1 and type 2 diabetes. Okay. Um, so do you have a specific example of that? Like for people with, so for people with type 2, generally the advice is that if they miss a dose, just they just skip it and take it at the next usual time. Now, for if you're on Tresiba or things like that, that doesn't matter. Tresiba you can actually just take whenever, as long as it's 8 hours apart from the next one. That's what makes Tresiba very useful for travel as well. You don't have to adjust the dose because when you travel, you don't have to do all those insulin calculations when you go travel. So Tresiba is good for that. For type 1, that's a little bit more difficult. If they miss their basal, they'll probably have to do more bolus from the day to day uh, to get their sugars under control. So there isn't anything in the guidelines, but that's just general advice. Okay, I see in the chat there's a whole bunch of questions, so I'm just trying to do it one by one and trying to get everyone's questions. Why is hypertension screening in children done twice a year? I have no idea. I don't work in pediatrics and I don't know why it's just twice a year. Um, you would have to ask the guideline authors for that. So Kajal asked, can you help me understand do-it-yourself aid systems? Is it just literally a computer? So you can buy these online. I don't actually have a lot of experience with that. If anything, if the best person would have been yesterday, Anita, if you go ask for that. So apparently there's these systems that you can buy where you can just override the insulin pump settings and get it to adjust insulin the way you want to. Um, I've never seen that in my practice, but apparently it's popular enough that they had to actually give a chapter guideline on that. So yeah, it's something you do build at home though, to override old sensor an old insulin pump's settings, and then you can just adjust the insulin by as however you want. Hope that answers your question, Kajal. Jaber, can you help me review the general recommended medications for managing patients with both CAD and CKD? I'm a bit confused about when to use SGLT2 inhibitors versus GLP-1 receptor agonists. I'd appreciate any clarification on prevention. Okay, so let's take a look at that. So in the 2024 guidelines, let's see here. There are some classes of medications you would use for CD and CKD. So let's just people must be on the websites running slowly. Okay, So if you take a look at this, if they're above target and they have certain other characteristics, some medications are preferred over others. So, for example, if they have chronic kidney disease, we generally would recommend an SGLT2/1. Now, there are some studies, like the FLOW study, that came out that discusses GLP-1s as well. But for the purposes of the exam, I would go with SGLT2s. Same thing for heart failure. Heart failure has been most SGLT2s have shown evidence in heart failure. Now, another common question I get is if you look down here in the 2020 guidelines, it mentions you can use all three of them. Uh, Invokana, Jardiance, Forxiga. But in this one, if you look, it only recommends dapagliflozin or empagliflozin. The reason for that is, I was talking to Dr. Peterson yesterday about this, is because uh, Jardiance and Forxiga actually have specific studies in heart failure, whereas Invokana doesn't. So that's why Invokana was left out here. Now, most people do think this is a class effect, so you could probably use all three in real life, but for the purposes of the exam, I would just go with these two. In terms of prevention, generally you use one. You would use a medication that has demonstrated benefit. So the ones to memorize for the exam are dulaglutide or Trulicity, liraglutide or Victoza, and semaglutide, which is Ozempic. Now, there was a study that showed that oral semaglutide, Rybelsus, does also have CV benefit, but it came out in March after the deadline for new information for the exam. So I wouldn't use that for the exam. And then for SGLT2s, you can use Jardiance, epagliflozin, or Invokana, canagliflozin. Forxiga did not show significant CV benefit, so that's why it's not on there. So it's these five you would memorize for the exam. Um, yeah, I hope that answers your question, Jabber. Okay, and let's see here. I found I got questions correct on SGLT2s for HF and CKD. Okay, I don't understand that question, Anna. If you want to unmute, you could. Empa, yeah, I don't understand that question. Okay, Jane, for a weekly, the once weekly insulin, notes that some patients require a one additional. Oh yes, you emailed me this, and I didn't get to it. So a weekly is the new once a week insulin. I think it's going to become very, very popular. Actually, it will be on the exam. It came out in like the summer of last year, so that meets the exam deadline of February 1st. The additional dose is typically at the beginning. So let's say you're switching someone who's on 100 units of insulin to a weekly. So you would switch them to the typical dose switch is if they're on 100 units daily, you would switch them to 700 units weekly. But for the first dose, you could increase it by 50%. So that means 1,050 for that first dose as a loading dose, just because a weekly takes a long time for it's a very slow acting insulin, obviously. It's given once weekly. And so because it's given once a week, uh, you can give a loading dose of plus 50% on that first dose just to get it into the system quickly and get the sugars down. Some people do that, some people don't. I believe Dr. Ask Jane actually recommends doing that. I, but I've done it a couple times, and I don't know, just the dose that just seems like a crazy dose to give 1,050 to someone. So I haven't done it in my patients, but but the couple patients that I've had were kind of more on the frail side, so I was a little bit afraid to prescribe such a big dose. But from other people I've heard, that is something that you can do. The main benefit of, yeah, so the main benefit of a weekly is that it is less injections. Everyone wants to go once a week. Nobody wants to do daily. Um, from a hypoglycemia standpoint, the risk is low. However, there is some in the type 1 update, it did say that hypoglycemia was actually doubled for people for type 1. So the guidelines were actually not recommending people, well, not recommending, but kind of throwing shade at the idea of using a weekly for type 1s. You still can, it's indicated, but they found that they had twice as much hypoglycemia. So that is something to watch out for. But yes, the main benefit for, say, like type 2 is just less injections. Okay, how much are we expected to know about travel and insulin adjustments across time zones? You do need to know that for most basal insulins, except for Tresiba and weekly, you do need to adjust. You don't need to know like all the time zones or anything like that. You just need to know that if they're traveling this way, they need probably less. If they're traveling this way, they need probably more. If you look at my after exam review, I do have a presentation uploaded by Dr. Where's that? By Dr. I forgot her name. Hmm, the website is slow. There must be tons of people on. Where is it? Here, Dr. Halpern. So if you click on this, and then you click on this, you will see Dr. Halpern's presentation, and it has some examples on what to do with travel and insulin. So yeah, there might be a question that shows up on it, there might not. Like, I don't know what's going to be on exam, but typically it has shown up on exam. So I hope that answers your question, Gaia. Okay, next question. George, can you clarify the recommendation on IP insulin pump criteria? Is it mostly the willingness to use it and the ability to use it? So the answer is yes. Anita yesterday talked about how basically you can offer it to anyone out there. Like it used to be in Calgary, in Alberta, you used to have like an A1C below 9 twice in a row to qualify for the provincial pump program. Now they've taken that away. And as long as you're willing to use it, willing to learn how to use it, it's a recommendation. You can recommend it. So yeah, a lot more patients. Hope that answers your question, George. Okay, Syed. 8-year-old with 8.9 blood glucose. Do you recommend taking insulin before the flight? Um, like what's the situation? So that's would be technically yes, they're above target. And if there's nothing else, then yes, I would recommend taking insulin. Uh, I hope the mother bought some carbs and insulin and glucagon just to make sure they can deal with it if they have a low. But if it's a flight, yeah, absolutely. If everything else is equal, yes, absolutely, they would take insulin because they're above target. Okay, IG. Oh, no problem. Thank you for the kind words, IG. Several questions. For HF, would you only use that? Oh, okay, so I kind of answered this question already. So Um, in real life, you could probably use all three of the SGLT2 inhibitors, but DAPA and EMPA seem to have more evidence for it, so that's probably the ones I would default to. Um, if for some reason their insurance only covered Invokana, yeah, I would use Invokana, but because there's more evidence for DAPA and EMPA, I would probably pick one of those two. Okay, if you have time, can you review screening for complications so this is Shanaz. If you have time, can you please review screening for complications in type 1 diabetes? Yes, that is hard, unfortunately. I have a cheat sheet for that.
Yes, I've gone through
Oh,
the cheat sheet
okay.
and I
Hello.
still get them all mixed up. So just a very quick 2 minute, I might remember it more.
Sure,
I
I
don't know.
can.
I get them so confused, and I've done your exams as well. like 3 times, and I still get them confused. So I'm
It,
really sorry.
no problem. It is hard to memorize. That's why I had to create a cheat sheet for them myself. It's hard to memorize. So I guess a way to try to remember them is that uh like for type one, like so for type two, like if a guy wanders in, he has type two, we don't actually know how long he has had type 2 for. Like his A1C could have been like 7.5 for years and he didn't notice. And this is his first time seeing a family doctor. In Alberta, we kind of have this family doctor crisis right now where people can't find a family doctor. And then people will come in, it's like, I haven't seen a doctor for 5, 10, 15 years. And oh, now you have diabetes. So how long has he had diabetes for? It's hard to say. So here we go. So in those people, we test right away because we don't know how long they've had diabetes for. For type 1, it's different. Usually they're very ill very quickly, and usually they're not waiting. If they're severely ill, they're not waiting for 10 years before seeing a family doctor. Um, so yeah, and so this depends on, like, generally wait a couple years before screening for anything, because if you screen right away, uh, they're not gonna have anything because they just got diabetes. Generally, it's 5 years, depends on if it's a child. But yeah, unfortunately, like it's just a whole bunch of memorization that you need to do for the exam. Uh, I know it's tricky. Like I don't work with children at all, so I have to, every time the exam comes up, I have to rememorize this because I don't know for children. I just work with adults and it's like immediately for adults. So yeah, unfortunately, other than the cheat sheet, I don't have any like tips or anything like that. But just keep trying with the quizzes and hopefully you'll get it.
Yeah,
Okay, thank you.
uh, can I help here?
Oh yeah, sure, Jabba.
Yeah, it is something like I connected together most of screening in 15 years in puberty age. Like I connected, I always remember it like that, 15 years, starting from 15 years and 5 years, more than 5 years. It will work for retinal, it will work for neuro, it will work for all, screening. But the only one earlier is the nephro at 12. And still the condition is there, 5 years and above. So always 5 years and above is there for all the disease, And for dyslipidemia, twice at age of 12 and 17. I hope this helps.
Thank you. That is helpful. Does that help,
This is
Shanaz?
my
Yes,
little cheat sheet.
yes, yeah, just grouping them really
Yes,
helps. Those two,
yes,
nephropathy and dyslipidemia, seems
yes,
to be 12 and 15. Okay,
yeah.
perfect.
No, actually, only nephropathy at 12. Dyslipidemia a little bit different because like there is fat. I just connected this way, 12 and 17.
Mhm.
Yeah, unless there is risk factors, another risk factors, as most right there. Yeah, hypertension is the rules always for pediatric type 8, type 1. It's twice yearly for
Mhm.
for some for some reason. Yeah. Thank you.
Thank you. Thank you for that. And thanks for speaking up. That's really helpful. I'm looking for this to be interactive. I don't want to be the one talking all the time. So if you have a tip to answer one of these questions, please just unmute and ask away. Okay, so Anna. Oh, thank you. That's no problem at all. IG, is it possible to write up a cheat sheet on your website for indications? Um, I could. I can't do it like right now, right before the exam. But um there's already, if you, okay, so I know the 2024 guidelines, it's not as clear. But if you look at the 2020 guidelines, they do kind of have a cheat sheet for this already. Let me show you. This is IG's question. Boom, 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 boom. Here. Okay. So if you look at here, so this is the 20, this should be the 2021. Good. Okay. if you look here, this right here, like if they have heart failure, then it's SGLT2. If they have CKD, it's generally SGLT2. If they have previous CVD, it's GLP or SGLT1. So I could make a cheat sheet to try to make it more easier, but I wouldn't be able to do that before the exam. And there is just right here to try to help you out there. Okay, I hope that answers the question, IG. Okay, so no problem, Jane. I'm at Jane 515, IG at 517. Would you mind? Okay, sure. I know which question you're talking about. So for that one, poor foot care is not a cardiovascular risk factor. It's just he takes care of his feet poorly. Doesn't mean he has neuropathy. He doesn't. But yeah, that is a tricky question. But I want my questions to be a little bit tougher than an exam. But sure, let's take a look at that. It is right here under screening for CVD. Where is it? Yeah, I think that was, I have that question. I remember, I know which question you're talking about. His poor foot care, that's not a risk factor. So here's the things. So the guy was 40 and he had poor foot care. So that was I believe it's a not question too. So that one's especially tricky. But these are the screening guidelines for the for getting an ECG. Yeah. Okay. No problem, guy. Gaia. IG. Usually use premix if consistent meals at regular times, but what if this is an elderly patient? Do you switch them to long acting? That depends on the situation. Like the main benefit of premix is that just less injections. And for people who work in nursing homes, like it's a very, very hectic environment during meal times. And so it's nice to have it's easier for the patient and easier for the nurses if there's less injections. If everything is good, like if the A1C is good, if they're not having lows, I wouldn't switch them to a long acting. If they're doing well, there's no reason to. But let's say they're having lows or their meals are kind of becoming erratic, or let's say they're not getting good control and because premixed have fixed, 50-50 or 30-70, and we need to adjust one of them, we can't break it apart. We can just give the 30-70 or the 50-50. So if they're not target, or if they're having lows, or if there's a problem, yeah, you can switch them to a long acting. But if they're doing well, there's no reason to get them off a premixed. So hope that answers your question, IG. Anna, is there an easy way to memorize the mechanism of actions for all the anti-hyperglycemic agents? Not really. If you kind of think of it as, if you kind of think of the organs, like you can kind of look at what them and say, okay, this one affects this organ, this one affects that organs. I think that maybe will make it helpful to memorize. If you think liver, okay, it's metformin and it's working on reducing the amount of sugar that gets into the system. Or you think kidneys, oh, then that's SGLT2s. Or if you think stomach, it's GLP-1s or acarbose. That might make it easier to memorize. That's how I learned it. So that's how I know it, I guess. So I think that might be easier than this weird name that does this weird thing that you don't know about. Like, I think it might be easier to, associate them with an organ, and that'll make it easier to memorize for an exam. Okay, so I'm down to Sarah. Uh, just So they will typically let you know a month afterwards. Usually in July sometime is when they'll let you know if you passed or not. They won't give you a mark. It's a straight pass fail, and they'll email you sometime in July, and you'll know your answer then. And if you do pass, please send me an email. Let me know that you pass. I love to hear from students. Also, as well, uh, even when this course is over, if you do have, I don't want people to just get their CD and then not use it and not practice in diabetes. So if once you pass the exam, whether you pass or not, whatever, but uh, let's say you have a difficult case, feel free to email me and I will run it over with you, or an interesting case or a difficult case. I'll run it over with you. Now, in the summer, I don't check my email that often, so don't use it as some sort of emergency thing. Like, I'm not always around in the summer. But if you do, even after this course ends, if you do have a case you want to run by me, feel free to email me. Just make sure it's not some emergency case that you need right away. No problem. Um, Whoopsies, did I double on that question? Where am I? Oh, I think that's it. Okay, perfect. Okay. Anyone else have any questions?
And I'll just ask quickly, verbally,
Yeah, for
if
sure.
may, just with regards to the screening, nope, your cheat sheet, your wonderful cheat sheet on all the different studies for diabetes, that we have for us. Here I am. I'm
Yeah,
just
hi, Penny.
curious to know, how much do you think is really, really important? Like, we know that there's the standard, the DCCT and
Hmm.
the UKSPD, like those are important to know about. And the Accord, yes, and now we're talking about this Today study that they didn't bring up before, but like really, there's so many different studies,
Hmm.
the veteran study, the blah, blah, and there's what? Like, how many will they really, really expect us to know? Because it's a bit overwhelming, especially because there's numbers that are involved with them, and we have to know that, yeah, that this decreased by 76% in like retinopathy and blah, blah. It's a lot of different numbers that I'm not sure if it's the most important when I'm looking at all the whole guidelines that we should know.
Great. That's a great question, Penny. So, in the last couple of exams, the UKPDS and DCCT haven't shown up actually. For some reason, the Today trial keeps showing up. Um, but in terms of the drug studies, definitely you don't have to memorize like the names of them. You just need to know what they were good for, SGLTs for heart failure, GLP-1s for cardiovascular disease. Some of these statistics might show up like what's the population, what percentage of Canadians have diabetes, what will most people with diabetes die from, so I know you already have a ton of numbers in your head and you don't want and there's no need to memorize more. I would say this is a kind of a lower priority now. There doesn't seem to be a lot of questions on this. But some of
You put one
these
on one of these questions was on your practice exam.
it was.
And I
It's
went, what? And then I had to just go, I don't think it was that. I don't think it was that. And so it made me think probably more than that 1.5 minutes that I really should put on one question. So I thought, my God, do I have to know all these studies? That's why I'm wondering, like,
Mhm.
did you put it there because you think it's actually a really important thing or not?
It has shown up in like I've written an exam multiple times, but it has shown up in my exams. So but I haven't heard it show up lately. So that's
Okay.
why. So it could. So that's why I put it there. Like, hopefully it doesn't for you,
Yeah, about
but
to say, that'll be hopefully it doesn't.
hopefully it doesn't
Okay.
for you. But it did. It did show up in a couple of mine.
Okay. Thank you very much.
No
Thanks for all
problem.
your advice.
No problem. Okay, where am I? Does anyone know if oh yes, they'll be automatically submitted. Okay, good. Wonderful. Jabber. Okay, the dapagliflozin. So this one is really frustrating. Like if you look at the product monograph, and I'll show you it right now, it doesn't have that anymore. So I don't know why they would put it in the guidelines. And That's really frustrating. I don't know if that's a mistake on their part or something. But then I don't know. And then I've had two people email the CDECD and try to find out, hey, which version are you going with? And they haven't heard back, which is kind of frustrating as well, because you have better things to do than wait for the CDECD to reply back to you. But if you look here, like it used to be, I remember it used to be a black box warning, but as you can see, it's not here anymore. So I don't know why they still have it. I don't know why they still have it in the guidelines. Um, as a total guess, and I'm just guessing, I'm guessing that the CDCD will probably follow the guidelines and not real life. So that's what I would use for the exam. But that's just a total guess on my part. I've had two other students email the CDCB like weeks ago, and they haven't responded to them, unfortunately.
Okay, thank you. So still, it is required from us on the exam. Like if there is a questions, it is not one of the best options, right? To select in case that the patient have bladder cancers, select something different, another medications, right?
Sorry, what was that again?
Sorry, the questions is,
Yeah.
in case that we have a questions in the exam, what to answer? Is it contraindicated or is, you know, like,
Okay. So my answer is I'm not sure.
oh, okay.
Because I've had two students email the CDCB to try to find out which one they're going with, and then the CDCB did not respond to them. As a guess, as a total guess in the dark, I would go with the guidelines and say yes, it does cause bladder cancer. But I don't know for sure. Yeah.
Oh, okay, thanks.
No problem. I wish I had a better answer for you, but the CDCB did not reply to those two other students, so I don't have any info either. Okay, let's see here. So Anika is asking, when one of your medication presentations, you did mention sometimes like to include older medications like Actos. I haven't seen this medication in practice, and someone had mentioned that as well during the presentation. Can you clarify if the mention of these types of meds is common, like in the exam? It could definitely still show up on the exam. In real life, Actos has fallen out of favor. It had a cousin medication called Avandia, and there was some research that hinted that Avandia may actually have increased risk of cardiovascular disease events like a heart attack or stroke. That has been recanted, like there doesn't seem to be an association with Avandia and cardiovascular events, but that put a whole negative like a whole negative spin on that class of medication, and that medication isn't used much anymore in real life, but definitely it could still show up on the exam. For the med questions on the exam, Eleni is asking, for the med questions on the exam, have the answers question typically been similar to your med questions, like giving the option of drug classes or the specific meds, i.e., is it possible for two different answer options to be Actos or Avandia? I believe there's been questions of both. Like sometimes they'll ask about a class effect, or sometimes they'll ask which of the following medications is this. So you on the exam they used to only give generic names, but now they give brand and generic names. So you do kind of need to know the medications in each class. That one's a little bit easier to memorize because, like, for example, like even with Actos and Avandia, rosiglitazone and pioglitazone, they both end with glitazone. With the GLP-1s, they all end with atide, like semaglutide or dulaglutide, or like with the SGLT2s, they all end with gliflozin, empagliflozin, canagliflozin. So you probably need to know the names in each class as well. So yeah, I hope that answers your question, Nalini. Okay, perfect. The recommended dose, yes, so I believe it's 5 to 10. The recommended start dose is 10 units, mixed insulin 10 units, and 10 units before supper. However, in one of your practice, okay, I'll take a look at that. But I believe my cheat sheets, it says 5 to 10.
Yeah. And even on the site itself, there is two different information. Like in Appendix 9,
Mhm.
they mentioned the starting dose 5 to 10 units once or twice daily. However, in their insulin prescription sheet, Diabetic Canada, they write very clear, like 10 in the morning and 10 in the evening.
Mm.
So which one to follow? Like I find different informations in the Diabetic Canada as well. Like in the Appendix 9,
Mhm.
5 to 10 once or twice, but clearly on their insulin prescription sheet, in the back of that prescription sheet, they write 10 in the morning and 10 in the supper.
Yeah.
So like
I
it's,
would
it's
no, that's a good question. You're learning
yeah,
and there's different answers
yeah.
everywhere, which is frustrating. I'll just go with 5 to 10. That should be the right answer for most cases.
Yeah, here. Dosing.
Yeah, 10 and
Yeah.
10.
Yeah.
Let me just take a look here. Okay, no, it says here 5 to 10 as well.
Oh, okay. Okay, I should okay. So start. Okay. I thought this is the recommendation. Thank you so much.
Don't worry. I know there's lots of numbers. You're getting
I know.
confused.
I know.
I totally remember how I felt. Like, no.
Yeah. No.
Just,
Yeah. Sometime overthinking, Yeah.
yeah,
Okay.
don't overthink. Oh, and then there's one other thing I forgot. I should have mentioned. Never change your answer on exam. Like people, like when I talk to people who didn't pass, they typically changed most of their answers. Go with your first gut response, gut feeling answer. That's typically the right answer.
Okay.
Yeah, sorry, I forgot to mention
Thank
that
you
at the
so
beginning.
much. Thank you so much.
No problem. Again, if you feel nervous during the exam, do the
Deep breathing.
deep breathing.
Okay.
Here, I'll give you guys a funny story. I remember when I first, so if you have a complicated case, email me. Because I remember when I first prescribed insulin, this is a long time ago. Like when I first became a CDE and I first prescribed insulin, it was just to this really sweet elderly lady who lived alone. And so it was my first time prescribing insulin. I like triple checked all the calculations. And then like I gave her the prescription, prescribed it and everything. And then I went home. And then I had this like nightmare about, oh my God, she's gonna have a low, she's gonna fall down the stairs, she's gonna die. And then the police are gonna find out that I was the one who prescribed it. And there's gonna be police at the pharmacy to put me in handcuffs when I go to the pharmacy the next day. Like I know it seems ridiculous now, but it is like you should approach prescribing insulin cautiously. But it is normal to feel nervous about it. And so if there is a difficult case, feel free to email me, okay?
I'll share also because one of my friends, she told me she have to buy a food for one of the ladies because like she's giving her insulin and there is no food in her beside her when she visited her at home. So things happened. You're right. It's very scary.
Okay. Thank you for sharing that, Jabber. Okay. Do we have any other questions? Oh, I forgot. I should write these down. This presentation is being recorded. I'm going to upload it onto YouTube afterwards. Yeah, but so if you did have a question, you can look at YouTube later and review the answer. Okay. Alrighty, I guess that's everything then. I'll be on the exam forum all day. I have Thursday and Friday off. So if you do have a question, feel free to put it on the forum. I'll answer it right away. Okay. IG. Sure, no problem. Okay, IG. Is the new dose of Invokana with, let's take a look. I believe they did change that in the 2024. Let's take a look. Oh, my website is so slow. Um, okay, let's take a look. Yeah, so I believe they did change that. But now it's 300 milligrams if it's over 60, 100 milligrams down to 29, yeah, down to 30 basically. And after that, we would not initiate but can continue. One more question on tirzepatide. So tirzepatide came out a long time ago, actually, like last year. So it could be on the exam. Yeah, I hope that answers your question, IG. And Anika, yes, Monjaro could be on the exam. Tirzepatide came out over a year ago. The studies as well. That's a good question. It doesn't really show up in the guidelines, so I would know. That's a good question. I would know that I would know what Monjaro is. I would know that it is a uh, that it's a GLP-1. The Monjaro studies on CV, I don't think have come out yet, so I don't. Yeah, I
Sorry,
don't think.
it's
Sure,
Annika.
sure.
So with the tirzepatides, I was just curious if it would be on the exam, like, in regards to prescribing. Like, I know GLP-1s are not recommended for type 1s, but I've
Mhm,
seen it quite a bit. And even the reps have always said, like, oh, well, you can give the tirzepatide if they're on insulin to prevent any weight gain. And I know that, again, they're not recommended, but it's
mhm.
seen quite a lot in practice. So I was just curious if, like, questions like that when we're talking about kind of second line medications, would that be kind of like included, I guess, or
Okay.
considered?
I don't think so. I'm super surprised that drug reps would make such a bold claim. Um, like
It was
it's
an interesting presentation, just like in its entirety.
I see. I'm really surprised that the drug reps would make such a bold claim. Like, even yesterday when I was talking to Anita about adjunctive prescribing for type 1, she knows a bunch of endocrinologists that will not touch SGLT2s in type 1. And so for us to be, whoopsies. And so for us to be like recommending it or something like that, I think that's quite risky, like license and malpractice wise. So I would, for the exam, I would know that Monjaro is a GLP-1. Um, but I don't, its CV studies haven't come out yet, so I wouldn't worry about that. And for the adjunctive therapy, it'd just be kind of like the same as other GLP-1s. Like there's some benefits, but kind of risky. Consult a consult a specialist.
Yeah, like I just know the endo, what like a couple of the endos that I work with, one in particular, like he will always just crazy prescribe tirzepatides. Like he loves Manjaro. So it's so
Interesting.
interesting when you see it in practice and then like reading the guidelines, I'm like, whoa, that's not right.
Yeah.
I again, I'm sure like it's just the guideline. They're guidelines. They're not
Yes.
rules, right? So
Mhm.
I think that's just something that I have to wrap my head around all the time.
That's very interesting. There's also kind of different rules for specialists and other non-specialist prescribers, let's say. Um, to like a specialist can get away with a lot of other things that like we wouldn't be able to, let's say. Okay.
Yeah,
Oh,
definitely a fair point. There's just like so, and like I know Like we had our Manjaro wrap come in, like the Lily wrap come in the day after the weight loss, like weight management.
Is that bound? Yeah.
They just came out, like so it was on Thursday we had the wrap come in, and then the
Wow.
Wednesday. So we were like, and they're like, we can't speak on it now, and I'm like, didn't they just come out with this stuff? Like, so it's really interesting just to see all of that unfold.
That is very interesting. Okay. Okay, so I think that's all the questions. So again, I will be on the exam forum all day. If you do have any questions, please feel free to post them on exam. I do have Q&As tomorrow and Friday. They're just very casual. You don't have to attend them. You don't have to attend all of them for sure. Like just if you have a specific question or something like that. But I want to wish you all the best of luck on the exam, and just stay calm. You've worked hard. Just stay calm, and I wish you the best of luck. So thank you.
You.
No problem. See you later, Jabber. Best of luck, Jabber.
Bye. Thank you.
No problem. Thank you. Okay, let's see here. Where is my, here we go. And then